Thank him greatly for coming.
Thank you, Joe, for inviting me, and thank you all for taking time out of your schedules to be here. I just want to keep this informal, so stop me if you have any questions. And I'm hoping that you will take away something meaningful from this lecture where you can implement it in your practice right away. Just by way of introduction, if you don't mind, maybe if you go around the room. I think I know you, this is Jennifer.
Yes, pediatrics.
Wesley Woods, Emergency Department. David Hooker, ER.
Ryan Klein, ER.
Your thing says University of Kentucky.
That's right, it presents it.
Oh,
Right.
Outpatient. Outpatient, ER, outcomes.
Portia, ER educator.
Bob Stevenson, ER. Or Chambers in the Emergency Department.
Wanda Delikowski, administrator for ER.
Joe Johnson, medical director at BD.
Luke West with Schumacher Group.
Scotty Reed, ER.
Shirley
Burns, nurse practitioner, ER.
I'm Diane Rushing. I'm sorry.
This is Tatiana, everybody. She's the pharmacist.
I'm the pharmacist.
I'm Diane Rushing from La Bonheur Provider Relations.
they were manager of insurance.
Amy Davis, ER.
Richard Mooney, anesthesia. Brad Womack, anesthesia.
Nice, very good. That's awesome. That's a wonderful, it's a nice sort of eclectic mix of people with different backgrounds. I think this will appeal to all of you all when we get started. So what I want to do today is maybe give you a little overview on the pharmacology and the principles behind the administration of intranasal medications. Then we'll talk a little bit about what the evidence is in support of use of these medications. And then after that, we'll talk a little bit about some practical tips on what you would need to do to be able to use this effectively. And then finally, we'll wrap up with maybe what are the common indications. It may extend even beyond anxiolysis and analgesia, especially for us in the emergency department. I think you'll find that there are some other uses as well for these medications. And then with me, I brought some very low-tech equipment, but we'll pass it around when we get to it. Just don't want to forget it. All right, so let's get started then. So who's heard of HCAHPS? Everybody's heard about it. So HCAHPS is the Health Consumer Assessment of Healthcare Hospitals and Provider Systems. And these are the HCAHPS is the score basically that all hospitals are going to be using to assess to assess patient care experience in your individual hospitals. And Medicare is going to publish all the HCAHPS scores on their website, and that's going to determine, once the Affordable Care Act fully gets implemented, HCAHPS scores are going to determine how hospitals are going to be reimbursed. So I would, and question number 13, I don't know if you've actually looked at these scores, but question number 13 is, during this hospital stay, how often was your pain well controlled, and how often did the hospital staff do everything they could to help you with your pain? And I'm going to tie what we're going to be talking about with this, because this shows that you are doing everything you can to take care of your child's pain. And this will go a long way in helping with your HCAHPS scores. So there are some indirect benefits of making sure that you're doing everything that's possible to provide pain less sedation, pain less analgesia. And it gives you another arrow in your quiver, if you will. And the final question in this survey is going to be, would you recommend this hospital to your friends and family? And I don't have hard data to back this up, but I can tell you that when we implemented intranasal medications in our emergency department, parents were happier. And it was we did informal surveys of parental satisfaction with this, and we were very pleased. And now it's become part of our day-to-day existence. Without this, I don't know if we can function. So what are the pharmacology principles of intranasal sedation? So the first thing is, why even use it intranasally? What's the advantage? Why not just use it PO? So the big thing with PO is, when you use, say, if you give PO Pershad, what's going to happen is, as the anesthesiologist will tell you, the vast majority of that is going to be metabolized in the liver. So by the time it gets to your systemic circulation, you're going to have bioavailability is going to be much more with PO medications. Besides, PO medications are going to take time to work, especially if we're in the emergency department setting where time is going to be of essence. When you're busting at the seams, you really don't have time to wait for an hour. Or when you're waiting to get a case started on a child with tonsillectomy, you want to start an IV and give him some sedation. You can certainly give him PO by that now, but you also have an option of intranasal. And with intranasal, the principle is, if it is administered correctly, then it's going to get absorbed directly into the systemic circulation. It's going to bypass the enterohepatic circulation of the liver. So your bioavailability of the medication is going to be better, and it's going to be faster in your system, because it's going to go through the veins directly into your systemic circulation. So that's sort of the underlying principle of PO versus intranasal medications. The other principle to remember is, obviously, because you have a small nose and a small mucosal surface area, the concept is you want to reduce drug volume as much as you can, and you want to increase the concentration as much as you can. So if you're using midazolam, the preparation that you would prefer is 5 milligrams per cc, not 1 milligram per cc, and we'll talk about that in a minute. With fentanyl, for example, which is the other medication we use for analgesia with this route, it comes as 50 micrograms per cc. In Australia, where they use it a lot, fentanyl comes as 150. They actually have preparations where their pharmacy made 150 micrograms per cc at the Children's Hospital in Melbourne. So they use a much more concentrated version, and it gives you some advantages, and we'll talk about it next. And the advantages, when we talk about optimal volume, so you can't flood the nose with 5 cc's. The optimal volume is going to be 0.2 to 0.3 cc's, max 1 cc per nostril is going to be your max. If you give more than 1 cc, it's going to drip down, and they're going to swallow it, and it's going to defeat the purpose, or it's going to flow out. So the optimal volume is going to be 0.2 to 0.3 cc's. And Lutz should be giving you a handout which should have some of this information in there as well. Our protocol is in there. What's adequate dosing? Now you need to also have adequate dosing. Adequate dosing, and we'll talk about the specifics later, but the key point to remember is it's higher than PO dosing. Sorry, higher than IV dosing, I'm sorry. So if you're using IV midazolam, you're going to be giving 0.1 milligrams per kilo. But with intranasal, you may be giving 0.3 to 0.5 milligrams per kilo. So the dosing is going to be higher because although bioavailability is better than oral medications, it's not anywhere near IV, so it's going to be 70 to 80% of IV. Does that make sense? So you have to give a higher dose, and an adequate dose. And then the other advantage is you want to increase the mucosal surface area for absorption. So one way of doing it is using both nostrils. That will double your mucosal area. So that advantage you have with intranasal administration. Now you can also give buccal medication. So you can use the same concept and spray buccally, meaning under the tongue. If you give it, it's going to get absorbed through lingual veins into the systemic circulation. So you can do that as well. A little bit harder, but intranasal is probably going to be a little better. And then the delivery system. A spray is obviously going to be better because when you have a mucosal surface, if you drop it in, then it's likely to just flow out or flow back. Whereas if you spray, then it's going to get absorbed better. And to spray, you need an atomizer. And that's what we typically have, is an atomizer that hooks up to a lower lock syringe, and you can just load whatever you need in it and then squirt it. I'll pass it around. So that's sort of the concept, if you will, the key concept to remember. Let's look at the evidence behind the use of these medications. So I've given 2 articles that should be in your handout as well. Both are from the Annals of Emergency Medicine. This first article, published in 2011, was from the Seattle Children's Hospital group that basically compared oral, intranasal, and buccal midazolam for laceration repair. And what they did is they recruited 177 odd kids, and they randomized them into these 3 arms: oral, buccal, and intranasal. And they were used for laceration repair, like I said. And they measured distress. The primary outcome for their study was measuring distress by the CHEOPS scale. CHEOPS is the Children's Hospital of Eastern Ontario Pain Scale, which is a standardized, validated scale that we use a lot for assessing procedural distress. And they were trying to see what their baseline levels were of CHEOPS just before they started the laceration repair. And then they measured other secondary outcomes, like parental satisfaction, duration of sedation, and that sort of thing. So their key results, what they found is, this is, you see this a lot in these articles, this is a box whisker plot. All it is it gives, this line is the median, and the top and bottom is the 10th and the 90th quartile of the range of values. But you can focus on the median because that's going to be the main. If you see with oral, this is the first CHEOPS score obtained after the start of laceration repair. So which medication achieved the lowest CHEOPS score is going to be the winner. Obviously with oral, the CHEOPS score range, it typically ranges from 4 to 13. So as you can see, buccal actually won out in terms of having the lowest CHEOPS score at the time that they started laceration repair. But intranasal midazolam also did fairly well. There was no statistically significant difference between intranasal and buccal in terms of the degree of reduction in CHEOPS scores. This is an important slide to remember because it talks about proportion of patients who achieve adequate sedation level for laceration repair. And as you can see with intranasal, more than 75% of their patients achieved adequate sedation level by about 20 minutes or less. So if you give it now, it still is not going to work, and you start the procedure in 5 minutes, you're not going to get the optimal benefit of intranasal administration. You want to wait for at least 15 to 20 minutes. With oral, like we talked about, it takes 30 to 45 minutes to work, and with buccal, it's going to be also a little longer to work. So although the buccal scores were better before they started laceration repair, I think the profile of intranasal and some other secondary outcomes were also better with intranasal. I'll switch to that. So this is a busy slide, but I want you to focus on, if you look at the parents that were satisfied or very satisfied with their sedation, intranasal, 89% of them were satisfied, whereas 70% were satisfied with the other two options. And if they were asked, would you choose the same sedation again, 85% of them preferred the intranasal to the others in terms of their scores. So secondary outcomes were better with the intranasal option. So you can go with either, but I think intranasal wins out by a tad, if you will. This second study is from Australia that I was telling you about. Here, they actually is a randomized trial of about 75 or 80 kids between the ages of 7 and 15 years. So now we move on from the younger age group into a little bit older age group, and these kids presented with fractures to the emergency department. So they wanted to compare IV morphine with intranasal fentanyl. And they used a concentrated version of fentanyl, which is 150 micrograms per cc. And they wanted to assess every 5 minutes. So the child came in with a broken bone to the emergency department. One group got randomized to IV morphine the traditional way. The other group got randomized to intranasal fentanyl. And then they measured their pain scores. Because they were older kids, they could give you a score, like the normal visual assessment scale. On a scale of 1 to 10, tell me what your pain is. And they did it every 5 minutes till about 30 minutes. Because by then they felt the patient would have got an x-ray, and you would have hit them as soon as they got to the door, if you will. So their dosing schedule was standardized for their study. So for example, if a child weighed 20 to 30 kilos, everybody got an initial dose of 30 micrograms. So if you were 30 kilos, you got 1 mic per kilo. If you were 20 kilos, maybe you got a little bit more. And then you could also get 2 more additional doses of 15 mics, and so on and so forth for fentanyl, intranasal. And then for morphine, you can see what their dosing schedule is. which is fairly standard dosing protocols for morphine. And then you can repeat them as well, about every 5 to 10 minutes, depending on their pain scale. And what they found is that the mean pain score extended over 30 minutes. There was no statistically significant difference between morphine and intranasal fentanyl. So the advantage for you is you can see most of them had a VAS score. Initially it was somewhere 7 to 8, so they were definitely hurting. And then by the time you reached 30 minutes, you were down to about 3 to 4, if you will. The point being that intranasal fentanyl has a potent analgesic effect that's equivalent to IV. The advantage for us in the emergency department would be, even before the kid gets an x-ray, even while they're going for x-ray, you can just go ahead and give them intranasal fentanyl, get the x-ray, come back, and then decide if they need an IV for reduction and that sort of thing. But you immediately help this child who's crying in pain. And going back to your satisfaction scores, I think it makes a difference. So what are the practical tips on administration of these medications? So the first thing you want to do is you want to at least inspect the nostrils for blood and mucus. If, by mucus I mean, if there is a lot of mucus and blood from an injury or whatever, then you may want to suction out. If the patient has an upper respiratory tract infection that's severe and the mucosa is inflamed and they're having a lot of coryza, that may not work. So you're going to have to use your judgment in terms of utilizing it. The next step that you want to do, I will tell you that midazolam does burn. So what we usually do is just tell the parents that it's going to burn for about 30 seconds, just because it's a very acidic type of agent. So, but usually that settles down afterwards. You saw in that study from Seattle, even though this was a problem, the overall parental satisfaction was still fine. 85% of them said we would have it again. So, and that reflects what we're seeing in practice as well. But it's important to tell them, if you drip it without an atomizer, it's going to burn a little bit more. With the atomizer, it's brief, because it just sort of gets sprayed and it's over with. What you just passed on. Keep in mind that there is a little bit of dead space in that applicator tip, and you can actually see it. So when you fill your syringe up with the dose of medication, and maybe more important for Katie to keep in mind as she gives you the medications, is there is a little bit of dead space in there, so you may want to go up by 0.1 or 0.2 cc's. You've got to factor that in your administration. And then you can titrate, meaning I can start with an initial dose, and then after 5 or 10 minutes, you can repeat it, just like they did in the Australian study I talked to you about. We generally may use it once more, but if it doesn't work very well the first time, you may try again, especially if you felt the kids were snorting and sputtering. You may want to try it again after 5 minutes or 10 minutes, but more than a couple of times, we generally then move to another option if it's not working. But you'd know by then if it's working or not. And then this issue of monitoring, and I know you would have to get this approved through your sedation committee and all of that, but this qualifies as minimal sedation for us. So anxiolysis by Joint Commission definitions is minimal sedation, so we don't generally monitor these patients. Now if you start using fentanyl and midazolam together, then we would recommend you put a monitor. But certainly in the critical care areas like emergency department, ICU, where we're using it, we don't routinely put a patient on a monitor with intranasal midazolam. So that's something for you all to think about as you implement the protocol. Now, if you look at the conservative option to look at this would be any sedative in any dose can give you a deeper plane of sedation than you anticipated. So that's going to be your judgment call. If say you've given somebody midazolam and they're in a deeper plane of sedation than just anxiolysis, then you may have to switch gears and say, hey, let's put them on a monitor. But by our current protocols, we don't have to be on a monitor to start with. It's just left to the provider at that point. We have not had any adverse events with these medications in terms of someone slipping into a deeper plane of sedation or having respiratory depression. And then that's the atomizer that I talked about. Luke had asked about getting this. There are a variety of vendors that sell this product, but we get it from Healthcare Logistics. And the average wholesale price for this is about $3.83. And that's for us at Lavano, so I don't know how that will work on So let's see what the range of indications are. So one could use it for, so say you have a 2-year-old with a big forehead laceration. Your current options maybe, let's give him IM ketamine, because that's not an age you can rationalize it, unfortunately. So you're going to have to either use butane, which I think is not in the best interest of the child. And when I mean butane, meaning just holding them down, is I think we're now sufficiently advanced with our science of sedation and analgesia that we shouldn't have to do that. I would resort to other options. So here, what we would do typically in this situation is give him intranasal midazolam, wait for 15 minutes for it to kick in, then go ahead and inject the laceration. Or if you're using a lac gel, then at T minus 30, put the lac gel on. At T minus 15, give them intranasal midazolam. And at T0, you test them and see if they have sufficient analgesia, and then you can suture. Because lac would be typically about 30 minutes. Do you all use lac gel and that sort of thing? Another example would be, so say you have a very complex laceration and you need to start an IV, or if it's a dog bite to the face and they need to be repaired in the operating room. And I'd love to hear after we finish this what your pre-op strategies are for anxiety and sedation. But to start an IV as well, you can use, and peripheral IV is one of the indications that I had, was you can use intranasal midazolam. Once they're a bit relaxed, then you can go ahead and give them, start an IV on them. Once you get an IV, then your options are enormous. So they open up tremendously at that point. So fractures we talked about, you can use intranasal fentanyl for analgesia. I wouldn't recommend intranasal fentanyl. You're not going to be able to reduce fractures with, but as a supplement to analgesia, it's not a bad strategy to use some anxiolysis, especially if you have a very scared person. Incision and drainage of abscesses, which is often the bane of our existence, certainly I know in a lot of hospitals and in the offices as well. You have kids with boils that you're stuck, they're extremely painful with incision and drainage. Lidocaine doesn't always work very well. And these kids are struggling, but you know if I just make a small incision, I might be able to get all of it out, maybe even in the office, I don't have to send them anywhere. You have an option where you can use intranasal and wait 10-15 minutes, or if you're using some EMLA or LMX cream on top of that, go ahead and then, and you can use a combination. You can use intranasal fentanyl if you're in the emergency department and Versed, and then in lieu of full IV sedation. So you're going to have, but you're going to achieve, remember you're going to basically achieve minimal sedation, maybe moderate if you're using both together. You may still have a child who's going to struggle a little bit because of anxiety, but they will have some amnesia. They won't remember all of the experience, and it won't be that much of a struggle, and especially if you can engage the parents to even hold the child. It may be easier for them to do it. And then CT imaging, I know that's an issue that Joe talked about for y'all, is having to get repeated scans because the child is moving and you're not getting adequate sedation. So that's an option. You can definitely use intranasal midazolam, get them relaxed a little bit. And in the CT, they do have I'm sure they have a papoose type thing. So they probably will be able to do it, hopefully a little better. But CT imaging is another option. And then the other two indications I want to talk to you about is status epilepticus and opiate overdoses. So if you have a patient who's coming in seizing, this could be a child, this could be even, actually there's data even adults now, that if they're seizing while you're supporting their airway, and before you even get an IV, you can just give them intranasal or buccal midazolam and get that seizure at least the benzos in and started early, and by the time you support the airway, you've got midazolam in the system, you've got an IV after that, you've got a head start on and some of your pre-hospital protocols, at least in Tennessee now, in the Memphis area, they can use intranasal midazolam for seizures in the kids. So that might be something you may also want to look at. And there's data on that as well. And then for opiate overdose, if your patient comes in with an opiate overdose, by the time you're supporting the area again, you can go ahead and give them naloxone intranasally as well. So let's look at, I didn't run through specific dosing with you, but let's look at sedation first. We have a shortage right now, and I don't know why, Katie, of this product, the 5 milligram per cc product. So we're sort of hamstrung and we're all hurting in the sense, hurting for the kids. So without this product, you're going to be stuck. I prefer to use the higher dose. I use 0.5 milligrams per kilo. So if you have a 12 kilo toddler, let's take 12 kilo toddler. So if I want to use 0.5 per kilo, I need 6 milligrams. If I need 6 milligrams, I need a little more than 5 milligrams. So let's say if I just use 5 milligrams, I need a cc. I can either split 0.5 in each nostril, or like I said, the max on each side is going to be about a cc. So you're going to load up a cc of this in your, it might even be better to do maybe 0.5 and 0.5. Squirt it on one side, squirt it on the other side, and then work, and then we get started. But if I have a 20 kilo child, and I want to use 0.3 or 0.4 per kilo, or 0.5 per kilo, then I need 10 milligrams of midazolam. And if I don't have a concentrated product, that's about the max I can give, 5 on each side, 1 cc. So you have some limitations in terms of what you have in terms of what you can administer. And you can use fentanyl as well as a combination with this in 1 to 3 micrograms per kilo. So fentanyl for analgesia, if your child with a fracture comes in, you can use 1 to 3 micrograms per kilo. So I may start with maybe 2 micrograms per kilo fentanyl. Remember, the bioavailability of fentanyl by the intranasal route is going to be about 60 or 70% of your IV. That's why the dose is higher. So initially when you implement it, you're going to get some pushback from, not pushback, but some inquiries. Is that really the dose you want to use? Is that really the dose you want to use? Yes, that's the dose I want to use. Am I giving intranasal 0.5 milligrams per kilo? Yes, that's what I want to use. So 1 to 3 micrograms per kilo. Like I said, you can titrate 5, 10, 15 minutes. You can give another dose to get some better analgesia. What I like to do is this. I give them a PO analgesic at about 15 minutes after you've given fentanyl, or go ahead and start an IV if they need an IV at that point. So by the time the intranasal starts wearing off, your PO kicks in about 45 minutes. So say you have a kid with a buccal fracture. You send them to X-ray, they've come back. You don't need to set them, you just need to maybe put them in a cast or a slab. And you can give them PO Lortab or something like that 15 minutes after you've given intranasal fentanyl. That way they have some reasonable level of pain control. And you're not going to need to sedate them. And then it's going to wear off in about 45 minutes. The intranasal stuff is going to wear off. For seizures, you can use the same thing. You can use about 10 milligrams in teenagers or adults. And like I said, you can deliver it immediately to allow absorption on the airways being supported. And then the opiate dosing is also something that we don't use this. We use these 3, the top 3. Now there's another option that I'll give you, and I think I'd love to hear from the anesthesiologist on it as well. Sufentanil is not very expensive either, but it's 8 times as potent as fentanyl. So if you want a smaller volume, you could consider using sufentanil instead of fentanyl. But I would probably try this, and if you're having a lot of, well, we're going with this, we're okay with it. But that's another option that you can have. Make sure I haven't forgotten anything on. Well, I think that that's pretty much what I can think of. But I'll open it up for discussion questions. I'd love to hear some thoughts from different folks.
I have a question.
Yeah.
When you do like ketamine sedations, if you get Pershad intranasally ahead of time, do you decrease like how much ketamine you give, or do you give the same amount?
All the same. You know, now the recent literature is saying that. Are you referring to intranasal or?
Yeah, intranasal.
Yeah. No, it's probably going to be the same. I think the big advantage with this is going to be to get that IV started for the ketamine, because IM is painful. Maybe even if you're using IM, maybe you can use it to get that jump started.
Are you guys using any intranasal ketamine?
No, not, but that's another underexplored option, definitely. I think the data has not been great because there's been a lot of vomiting associated with it, and they have relatively prolonged, unpredictable level of sedation with intranasal ketamine. So unless you have it's not been very favorable, at least the limited data that I've seen with it. Yeah.
Has anybody explored using half a dose intranasally and half a dose under the tongue?
No, there's no data that I'm aware of. That's a great idea. Why did you ask that?
The supporting percentages of satisfaction were just enough so that it may be, in my mind, perhaps helpful to be somewhere in between and get a little bit closer to faster action. The other question I had was, do you use nitrous oxide?
Yes, we have nitrous oxide. Are we using it as often as we should? We're not. Part of the problem is we use it in the old ED, and I was telling you this offline. When we move to the new ED, it's only piped in the dental room, and the dental room is a little way away from the main ED.
So you don't have a portable
You don't
unit?
have a portable one. It's piped into the wall. But that's if you can get that. I mean, St. Louis uses nitrous all the time. St. Louis Children's. That's a great option. But maybe the anesthesiology folks can help you with that. But there's enough data on use of nitrous because a quick on, quick off. Max of 50%. When we used to use it in the old hospital, we had like a blender, one of those dental MDM matrix products where you always had oxygen flowing. You could not go any above 70%. But then you had to have a scavenger system also when you had that special room that we had had that taken care of. And then we used it and it was great. And we had like these nasal hoods that they use for dental things. So the issue for us was we could only use it in the older patient, like a 4 or 5-year-old or older, that we could tell them to breathe through their nose. Because if you put it on a 2-year-old, they're all going to breathe through their mouth and you're going to lose the effect. The anesthesiologists, obviously, they use an orofacial mask when they're using people, so it's easier. But St. Louis Children's had fashioned an orofacial mask that they use in their own ED, that they collaborated with the dental department and figured something out with their engineering department or whatever. So they've got something that they've created that they have a orofacial mask with the portable dental machine. Long story short, works well, especially use that, inject the laceration or suture the laceration and then you're done. IND, great. But unfortunately, we're underutilizing it right now. Yeah.
Do you know, where I trained, we would just use drop intranasal, we wouldn't use an atomizer.
Yeah.
We always talk about laryngospasm and stuff in certain patients. Do you notice a propensity for laryngospasm?
There's nothing that I'm aware of that's reported. And I think that the drop is also fine. I think you're going to save the expense, I guess, of the atomizer. The only problem with the drop is I think it's a little, the absorption may be a little unpredictable. It burns a little bit more with my line, and it's difficult to. But if the patient's seizing, for example, drops are fine. You don't need an atomizer.
I have a question. If you were talking to the parent of someone a child you're about to sedate, anything besides the burning, the Pershad that what do you discuss with them?
Yeah. That's a great question. I think two things. I tell them, look, one is we want to do everything for your child to control the pain and relieve his anxiety. When I inject his laceration, it's going to cause a lot of anxiety, so I'm going to be using a medication called Pershad, and I'm going to be using it in his nose. It's going to be relatively painless, other than a little burning initially. And with this, they will be relaxed, and they'll allow us to proceed with with the numbing of the laceration or the repair. That's all I tell him. And then I tell him is he may act loopy, he may act a little disinhibited, like sometimes those kids after we're set up. But I do tell him that he won't remember this and he will be more comfortable with it. So, and then I also put a qualifier, and I would say that it doesn't work all the time. I think it's a good strategy for these non-IV options, because sometimes it really doesn't work very well. So then you just have to backtrack and say, so I say maybe 10% of the kids, it may not work. Most of the time, when they see it's painless, it's intranasal, it's like spraying Afrin, you know, or something that I generally use. It works.
As a single agent, you don't really warn them any more than you would if you were thinking of giving them a dose of morphine IV.
So I would not all.
Once reaching close to the 1 ml,
What's that?
you seen any gagging or
Yeah.
or choking?
Not gagging. Yeah, if it drips down their throat, they're gonna gag a little, definitely. The problem happens is the initial phase is the hardest, because if you have a pre-verbal child with tremendous stranger anxiety, how do you get it in their nose? So you have to hold them still. So that part is the challenge. And then you want to make sure that it's in the nose and you're squirting it. But it's brief. It's 5-10 seconds and it's over with. So I'm not going to, and I think that's a great question you asked, because I think you don't want to, I think it's a great agent. And if it works like a charm. But in those cases that it doesn't work, it's natural for us to feel, a little disappointed. But I think if you expect that, and the parents expect that, we haven't had. And I'll tell you, 90% of the time, that HCAP score thing is not just for the score part of it, but just the effort that you're making, that I'm doing everything in my capacity to help your child's pain or anxiety. And most parents appreciate that. If it doesn't work, it doesn't work.
Mechanically, is it any better to have them sitting up, laying down, anything like that?
Good question again, yeah. I think it's better like that, in a sniffing position. So typically, if you lay them back, maybe in the parent's arms, and then have another person with you holding the head, and then do it. Yeah. So they don't have to be laying down, but yeah, that position is better.
Just the head tilted back.
The two that I can send you more, I thought this was the most robust data that we had in terms of pure, and I would encourage you to read and our protocol is in there as well, but I would encourage you to just sort of read the discussion section on both the intranasal fentanyl article and the midazolam article, because I think they're fairly recent, so they do compare their work with the existing literature and do give you the strengths and limitations of this type of administration. And then if any of y'all want to come down and want to just take a look what we're doing over there, if you call me or if you call Diane, I think we can work. The hard part is going to be, one of the docs from Oxford came down there in Mississippi to take a look, and one of my colleagues was helping him. And they waited for like 4 hours in the ED, and we didn't have any case. So that became a little. But you can come and just observe and see what we're doing, and if you have any other, if you come with sort of a few things I want to see how we do with kids, we'll be happy to share with you. Stuff is happening all the time anyway. So.
Are you using it anywhere besides the ED?
On the floors. On the floors we're using it, and on the floors we are requiring them to put them on a monitor. And I think that's going to be the issue going through because they are non-critical care area, and they're not, the level of monitoring is not going to be the same in terms of nursing. Because I'm not going to say there's going to be, if I say it's never going to cause respiratory depression, you're going to hold me to it. That's not the case. I mean, I'm sure there's going to be, anytime you're using an agent like that, you can't have it. You were smiling and you had some other
No, I was just laughing as you said walk before we do monitor. Sounds like an excellent idea.
That's an idea, okay. Yeah. But you know, if you have an inpatient there for on this, and just trying an IV, the nurse is trying an IV, they can use that option. You know, the thing is, we've empowered our nurses, which is probably the easier way to go now, because the other ones were initially starting the IV, the other ones were initially encountering the pain when the kid comes in with a fracture. That what they would do is they would come to us and say, can we give intranasal? So now, or the cat performing a bladder cath on a 2-year-old female, you have to hold down and do a catheter sample. That's a patient that they're going to come to us now. They're going to say, I want to give intranasal. Sure. So we still can't, they still can't, we don't have protocols where they can put the order themselves. We still have to sign off on it. But if you give them a verbal yes, they just go ahead and move forward with it. And having a pharmacist in the ED is also made it a little simpler, because when we got this protocol approved through our PMT committee and our sedation committee, I think we had active, way we did it, Joe, is we first did you have the literature now, so we didn't have all that literature at that time. We had the support of our anesthesiology group, and then we went ahead and did a pilot thing, 20, 25 kids. And we collected some data in terms of basically safety, that it is safe. Because a lot of times, because it's something novel, we've not done it before, that's sort of the anxiety. And then once you do 20, 25 kids, you find everybody's comfortable with the pharmacy's engaged. And then you have a protocol that you draft, and you can use the protocol you have, tweak it to your needs. And after that, once you find that you have parental satisfaction, you have satisfaction on nursing end, satisfaction on physician end, then provisionally you can get approval, and then you can get full approval once you run with it, type of thing. If you encounter some resistance to it, which I don't think, because it is still minimal sedation. It's in worst cases, you can say, I'm going to put them all on monitors to begin with, especially if there's fear that some child is going to slip into a deeper point.
And mechanically, and there may be some legal hurdles on that, I don't know, but mechanically, does the nurse themselves administer that?
We don't have to find out from state board.
Right, to see what the laws governing nurses are, but I just wondered what your practice was.
That's a great question. I have never administered it, I just seen them do it. I know what they do, but you sign off on the protocols. And you know, really, I think it's, and it is a team-based approach. Certainly, I think, sometimes I feel that the nursing staff, at least in the children's hospital, I think they're so attuned to kids' pain, suffering, and all of that, much more than I feel that we in the physician side of it are. So, if we give them the tools, they'll figure out the best one for them, for the child, and I think then we go with that. And now I think it's rare that we would ever cath. In fact, the first thing they say is, on a toddler, if you have to cath them, is, shall we use something? Because it's also not very labor intensive. It's maybe a little added cost to the care, but in terms of it's much less labor intensive, as you were saying, than doing other options like IV.
Or having to get 4 people to hold them down.
Yeah, exactly, yeah. Or maybe a lumbar puncture. I don't know, we haven't had I haven't done LPs with this. Usually if I'm doing an LP, the child's sick enough to need an IV, labs, in which case I'm usually having an IV, so then I would use IV Versed. Certainly, I mean, IV Versed is going to be your best option, but we're talking about alternatives.
After overdoses, you come in, you can get an IV quick, use that amount of.
Right. Part that we found is, you have someone who's a chunky child who's seizing, or one of those kids that are physically challenged with contractures and difficult access. And some of these parents use rectal diastase. I'm sure people in your practice Some of them have used it, it's not worked, and they're calling EMS, and they're still seizing. Access is difficult, so you can either give IM or you use this option. And so that's certainly. Do you have this concentrated preparation right now, 5 milligrams per cc?
I think we do have some. I don't think we have a large allotment, but I think we do have some right now.
And I can hook you up with, or Diana, or one of us can hook you up with our pharmacist. If you'll move forward with this. Well, I would overall, I applaud Joe and the emergency department team for taking the initiative on this. I mean, I would support it. I think this is great for the kids. And I think it gives you an option that we never had before. And I think we've got sufficient data now. It's backed by evidence, and we know it works. And we're improving patient satisfaction scores. Now, do I have evidence of that? But that's another area that you can target when you implement the program. Maybe you want to see in your outcome type stuff that you're looking at. Maybe you can address that very question for adults as well, pain. And isn't that an issue also for adults side?
Tell me again, when you started practicing this at Low I couldn't remember, I couldn't hear what year you said you started.
What we started?
Yeah, well, when? Like, how long you been doing it?
How long have you been doing it? I can tell you exactly. I want to say 2 years now.
Okay.
One of our physician champions on this was Dr. Cox, and the pharmacist who was Megan, who really actually went to I think they visited St. Louis, because they were already doing intranasal at that time, and came back, drafted the protocol, and they ran with it. Then they collected the data, and then they presented it also at a quality council meeting, because the results were so positive, both on the provider end and on the parental satisfaction. And, so 2 years ago. We've had, I think, medication shortages have really put a bump in the road, if you will, and I think it's everywhere.
Thank you very much.
Thank you. It's a pleasure.
Thank you very much.